So looking at sleep apnea, in particular, I'd say out of all the areas we treat, and that's a big one, that's an area where there's the most misunderstanding, misdiagnosis,
non-diagnosis,
undertreatment, poor treatment,
over-treatment in some regards.
It's just a certain kind of show. That's not a good show, kind of a thing. I mean, it's just there's and it has never been ever since the dawn. So it's sleep apnea's been around since the dawn of humankind, but the diagnosis of sleep apnea came about in the 80s, so it's not that long ago.
Mm-hmm.
It existed before then, but we didn't have any way to measure it. And the deal with sleep apnea is that in order to measure what's happening, to test what's happening, you have to do a sleep study. Okay. Fine. Back in the old days, the only way to do a sleep study was in a sleep lab, and the sleep labs were run by pulmonologists who also then decided upon the treatment, which was a CPAP machine. So somebody has, just to kind of break it down, if somebody has sleep apnea, they have a throat issue, about 100% of the time. Like obstructive sleep apnea, it's not 95, 90%.
It's obstructive.
Obstructive
Yes.
sleep apnea, by definition, means you're obstructing your upper airway,
Right.
period.
Correct.
And so you have a throat issue 100% of the time. About 1 to 2% of those folks who have a throat issue are actually treated by a throat specialist like us.
Right. Which is crazy.
Which is crazy. Now, to flip that, and somebody says, if somebody were to say, well, buddy, I don't believe you. I don't think that can be that. There's nothing in the world that's 100%. And then the proof to that reality is if you have obstructive sleep apnea, and we do a trach. So a trach means we're going to put a breathing tube in your neck below your upper airway. We will cure your sleep apnea, your obstructive sleep apnea, 100% of the time. It's a cure.
Right.
So I think again, I'm not usually one about like 100% of this and that, but it's a throat issue. Like I don't know that there's much. I would welcome somebody to step up to that challenge and say otherwise.
And to clarify, there is something called central sleep apnea. Right. And that's different. And that's a brain issue. And that's a signaling.
Obstructive sleep apnea is your brain tells your lungs to breathe. Your lungs decide to expand, and your upper airway shuts down.
Yes.
Back of your throat shuts down. That's obstructive sleep apnea.
Right.
That's what that is. So that's what we're talking about. Central sleep apnea, which happens, it's very rare, but it does happen. Central sleep apnea is when when you're asleep, the brain forgets to tell your lungs to breathe to begin with, and that's a whole different issue.
Right.
That's a brain issue. Now, the reality is, this is not 100%, but I'd say almost everybody who has central sleep apnea has obstructive sleep apnea. Mm-hmm. It's very rare for those things, for central sleep apnea to exist without obstructive sleep apnea.
Correct.
If you have mixed sleep apnea, which means central sleep apnea and obstructive sleep apnea, the first line of treatment is you treat the obstructive component, treat the throat issue, and many times the central component will become better.
Right.
So even there, so not to confuse the issue at all, I'd say yes, central sleep apnea is not a throat issue, period. Though most folks who have central sleep apnea actually do have a throat issue because they have obstructive sleep apnea as well. But then back to obstructive sleep apnea, if you have a throat issue, the challenge is the gold standard for treatment is a CPAP machine, which is a machine that you put on your nose and your mouth. It pushes air into the back of your throat. It's basically just blowing constant, so continuous positive airway pressure, CPAP. That's what that stands for. So it's blowing, and by blowing, it's tenting that open. It's not delivering oxygen. It's just pushing air in to hold a tube that's collapsing, hold it open. That's what that is.
So why is that the gold standard?
Why is that the gold standard? You tell me.
Yeah. So I mean, and this is where this just doesn't sit well with me. Like we said, okay, so ENT doctor, throat issue, we should be treating that issue. The reason why a CPAP machine, in my opinion, is the gold standard is because, well, how was sleep apnea diagnosed? Usually sleep medicine doctors, pulmonary doctors. And so they use something that can be effective and work well for patients, but that is the only thing that they can give a patient.
Yeah.
And so for them, all the studies, all the treatment studies, everything else was based on a technology that, again, can be effective for some people, hard to wear, and we can get into that, but looking at a sleep doctor prescribing a CPAP machine.
Yeah.
Because they couldn't do anything else.
Yeah, because they can't. So their only option, if you're a sleep medicine, if you're a pulmonologist or a neurologist that does sleep, your only option that you can actively deliver to somebody is the CPAP machine.
Right.
Which is okay when it works, but the reality is it more often than not doesn't work.
Right.
So if 100% of folks who have sleep apnea have a throat issue, about 80 to 90% of those same folks also have nasal obstruction, and they may not know about it. So these areas are interrelated. So your nose and your throat, they kind of play in tandem. And so if your throat is tight, by definition, if you have sleep apnea, your throat is tight. And then by definition, so that's one of the holes you can breathe through, and then the other two, which are your two nostrils, are likely to be compromised. And so those things go hand in hand. And so if you're a lung doctor with a CPAP machine treating a patient with a throat issue and a nose issue, your machine that you're going to use isn't going to work.
Well,
it's not going to work properly.
Because, especially if a nose is tight, you're pushing it through a tiny straw versus a big tunnel.
Yep.
And so why do most patients end up getting full face masks? Well, because maybe they start with that nasal mask and they can't tolerate it because their nose is so tight. Then they get a full face mask slapped on them, and then it's really hard to tolerate that machine. And then compliance, right? This is the other thing that really vexes me is that, compliance from insurance, hey, this patient is using this or not, is based on 4 hours of sleep, 5 nights a week, right? And there's not a single person out there that tells me that they will feel rested. Let's say they didn't have sleep apnea and they were sleeping 4 hours a day or night, 5 days a week. Like that person isn't rested and they don't have sleep apnea.
So like follow the ball there. 4 hours of sleep, 5 nights a week that's the bar we're setting.
Right.
Which is a crappy, like that's a low
It's a horrible bar.
That bar, which is you're starting out like, hey guy, if you were saying we were doing baseball and you're basically saying, oh, like my bar is I need to be a 100 hitter to be successful. Now, in this, so the bar is so low, the likelihood they're going to hit that bar is about 30%.
Right.
Like you started out, your bar is ridiculously low, and you're not even going to hit that, and then you're going to accept that as we're all good, kind of a thing, which doesn't make any sense.
Or the thought that a doc would tell the patient, hey, you're compliant, you're using this and it's working for you.
Right.
When a patient's like, no, this ain't working for me.
Right.
But no, you're compliant, so it says that you are.
Correct. Yeah, it doesn't make any sense, but it's just how it is. I mean, there are a lot of things in medicine. So I think a lot of people come to our profession with an expectation that everything's been sorted out, like an ENT is an ENT, a sleep study is a sleep study, a CPAP is a CPAP, everything, this is the same. And I'd say, no, I guess it's, in my opinion, there are a lot of things. I mean, we certainly benefit from all the hard work that's been done up till now with all the docs and various specialties that have been, done that work. Wonderful. But the understanding and the treatment, especially for the issues that we deal with, are still pretty rudimentary compared to, things have not moved forward as much as they should. And part of that, I guess, and you said it before, but I'm going to sort of bear the cross on this, is that whose fault is it that lung doctors and brain doctors and psychiatrists are treating a throat issue? Whose fault is that?
It's the
ENT's
ENT's
fault. It's our fault.
Yes.
That's my fault, and that's your fault.
Right.
That's we absolutely bear the price for the sins of our fathers and mothers. That's on us. It doesn't mean you have to be sort of cursed forever. It's as well, we can own up to that. I mean, the reality is, if you have sleep apnea, what you deserve is to be treated by somebody who can offer all the treatment options that are available. That's my opinion. I don't think that's not sticking my neck out really far. That's just saying you got a throat issue. Maybe you ought to see somebody who can do a CPAP if that's appropriate, do an appliance if that's appropriate, do surgery if that's appropriate. Now, we as surgeons, rarely do throat surgery for sleep apnea. That would be the knock that a sleep doc would throw at is you guys are just looking at doing throat procedures for folks who have sleep apnea. It's rare. It happens. I mean, there are certainly people who are good candidates for throat surgery for sleep apnea, but most people aren't.
Well, and we certainly wouldn't necessarily do throat surgery if their nose was completely shut down too, first, right? So
Right.
throat surgery tends to be, longer recovery, more painful, typically on pain meds, things like that. So we use it wisely in the sense of when we decide to move forward with a patient on that, it's have we checked some other boxes and made sure that we haven't, to make sure that we've addressed the other issues that are easy to address first,
Right.
and then is this what makes sense moving forward?
Yeah, and I would say, and another way to say that a little differently is that, kind of, we were talking before about medications and those sorts of things. My personal opinion is if I have sleep apnea and I could rid myself of that issue without having to use a CPAP machine, that's how I would choose to do it. Doesn't mean
Sure.
it's right for everybody else, it's fine. The reality is, in the typical system, this medical system as it exists, if you go into any sleep center, the only treatment option is going to be CPAP.
Right.
And so that game is by definition rigged. It's rigged against you. It's a shakedown. It's not a shakedown that was set up to with ill will, I don't think. It was a shakedown that was set up because that's the only tool we have, man. Like I am a throat doctor, but if I wasn't a throat doctor and I'm seeing this problem, which is significant. I mean, there's millions and millions of people in this country who have sleep apnea that aren't getting treated.
And it's grossly underdiagnosed.
Because it's rigged,
Right?
Like because everybody knows that that thing's rigged against you. I'm going to go in and I'm going to get this study. I'm going to get a CPAP machine. And CPAP, we prescribe a lot of CPAP. We do. I mean, because it's an appropriate treatment when used appropriately. Unfortunately, is that machine that can help a lot of people is misused, and so it's like it hurts it both ways. Like you're misusing it when you could use it properly, and it just doesn't.
But we prescribe a lot of CPAP, having a full, transparent conversation around, hey, with patients, these are your options. They choose to do a CPAP machine.
Because we've looked at all the
Yes,
options, and
yes.
and it's not as there are times if somebody has severe sleep apnea, meaning their throat is super tight, and of course we're going to get their nose working before we do any of these treatments because it's necessary. And if CPAP's the right option for you, you're going to hear that. And you don't have to, we're not going to stutter. You don't have to read between the lines here. It's going to be really the right option for you is CPAP. Now that's some folks. Most folks have options. Most folks who have sleep apnea, machine is almost always, if somebody has sleep apnea that needs to be treated, then the CPAP machine is going to be a potential treatment option. But there are going to be other options. And so an oral appliance is a different way to go about it. It's basically like a retainer that you wear when you're sleeping at night that sits in your mouth, and it's just helping to open up your airway by using your teeth to open that airway up. Most folks who are candidates for CPAP are candidates for an oral appliance. Most folks who are put in or forced into a CPAP or told about a CPAP never hear about an oral appliance. And then again, there are some folks who would be good surgical candidates from a throat standpoint. Those mainly would be folks who have big tonsils or issues that we can get in there, get out of your way, and maybe you don't need a machine to push air at you, and maybe we can literally open the anatomy up. And so if we are suggesting that somebody starts with a CPAP machine, that is, here it's done with we are either approving your nose and how it exists, or we're gonna make it better. We're gonna make sure your nose is a good pathway for you to breathe because it's the start of your airway. So that's already behind you.
And the nose is the primary. The nose is the airway you should breathe through.
Absolutely, no question. But then if we are saying CPAP, that means like that's really a good option for you. You're going to know that we've considered all the other options. We're going to talk through those other options anyway. So it's not like you have to have any guessing games.
Well, and how many patients have you had come in here that maybe are on a CPAP machine? How many of them have ever been told about any other options for the most part?
I put that out to the world and say if you're in a CPAP, what other options were discussed with you?
Right.
And we see so many patients from so many different sort of broken systems that come in to see us that they just don't they can't. And part of that part of it is because they don't have the capability to do anything other than the machine. And so if you cannot put somebody in an appliance, you're not going to talk about the appliance. If you can't do a procedure on their throat, you're not going to talk about that. If you can't even look at somebody's nose or look into the nose or fix that nose, you're not going to talk about that. You're going to talk about this is the option. And so, and you just don't want to talk about whatever you can't do or say or control. It doesn't exist,
Right.
which is not. I'm not okay with that. I mean, I'm okay with. I'm okay with everybody bringing their best. If we're on the playing field, we'll bring our best game, and everybody else brings their best game, and we'll see, who's victorious on the field, and that's fine. Like, I don't have any problem. And full disclosure, here's how it is.
Yeah.
Wonderful. But some of the shell games that happen, especially in the sleep world and the CPAP world, it's not just sort of it's actively hurtful. It's actively, it's not passively hurting somebody, it's actively making a decision for somebody else that you have no business making a decision for.
Right.
That's not my job. Like, your job and my job is, as physicians and surgeons, isn't to take control of somebody and say, this is what we're going to do, without any, sort of conversation about it. It's a education, it's a discussion, it's a, let's, kind of work together on this sort of thing. That's just not how it's done elsewhere, because they can't do that. They can't,
Right.
They can't do that because it only works to kind of have that railroad mentality. So.
Yeah, yeah. I mean, one of the things that you always say that stands out to me is like, what's one of the greatest sins is, if you know of other options that are on the table and you don't present 75% of them because you can only do one, versus, hey, maybe if you're unaware of other options and you're presenting what you truly believe are the best options, fine.
Right.
You're doing the right thing, and I think that you're presenting as best you can. And if you don't know, you don't know. Now go learn about more
Sure.
things. But if you have lots of options on the table, and you, again, don't tell patients about 75% of them because you don't have those ability to give that to that patient, that's not right.
That's not okay. Right. And that's an opinion. I mean, maybe there's a counter argument. Maybe there's somebody in the world would think the opposite,
Yeah.
That's cool. I mean, I guess that's fine for them. It's just, that's not, like, it's not at all. And I guess I'd say our mindset, maybe it's the patients who come to see us. Maybe it's just because the folks are seeking out like-minded mindsets and attitudes. Maybe it's the prevailing attitude in the world around us is that I cannot recall ever sitting down with somebody and talking about sleep apnea and talking about the options where it's hasn't been received with. Doesn't have to be. You do not have to be thrilled with me telling you that
You have sleep apnea.
you have sleep apnea
Right.
and this is what we need to do better. You don't need to be like, sort of singing songs about it. But I think walking out of here with a thorough understanding about what's going on, why it's going on, and what the rational options to treat those issues are, like, that doesn't get old as a
Right.
construct. Like,
Yeah.
that's what we do. That's what we're here for, and and then each person gets to sort of make an informed decision based off the information. That's it.
Yeah,
It's pretty
and I
simple.
feel like, to the best of our extent, we are presenting every option that we know of, and that we can deliver on.